Good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by CareSignal, which is a Lifebeam company. And it is titled Your Roadmap to Building a Robust Health Equity Plan to Succeed in ACO Reach. We know there's a lot floating around about ACO Reach right now, a lot of questions in the air. So these guys are going to clear some things up for us today. So I'm really looking forward to hearing from them. A few items of note before we get started. All attendees have joined today in listen-only mode, so you don't need to worry about muting your microphone. That's been done for you. And during the webinar, we want to hear from you. So there is a ability to submit questions. We are going to have a Q&A towards the end. Would love to hear your thoughts and your questions for our presenters. So there's a question module, or a little on your attendee module, there's an area for questions, which is different than the chat. But go ahead and submit your questions there, and we're going to get to as many of them as we can today during the allotted time. If we don't get to yours for some reason, because we do have a lot of people on the line today, we will make sure to get to you via email afterwards. So please continue to submit your questions even if we're wrapping up. And finally, today's webinar is being recorded. So what I'm going to do is after the session is completed, I'm going to be sending everyone out who registered a link to the recording afterwards. And that'll also be a place where you can download the slides from today's presentation and interact with the team there. So without further ado, I wanted to introduce very briefly our presenters today. Dr. Kent Locklear, who's the Chief Medical Officer of Lifebeam Health Solutions. And also Joe McDonald, who's president and co-founder of CareSignal, which is a Lifebeam company. And we're excited to see you guys today. So thank you for joining us. I believe Dr. Locklear is going to kick us off. So welcome.
Thank you, Garrett. And hello, everyone. I was going to say good afternoon, but that'd only be true for half of you. It is our great pleasure to be here today. If Joe and I were more akin to George Clooney and Brad Pitt, we might stay on the camera for the entire presentation, but in order for you to focus on the content, we're going to drop off so you can focus on our discussion and our content. We'll jump back on at the Q&A session. So I'm going to shut off my camera right now, and we're going to get down to business. So again, welcome. Our learning objectives for today. So let me say at the outset that this is as much a presentation about the importance and the implementation of health equity as it is about specifically ACO Reach. We are going to focus on ACO Reach, but I want to reassure anyone out there that's not participating in ACO Reach, there will still be value in this presentation because CMS has made it clear that health equity is here to stay. So our learning objectives for today, it is clear that technology and its positive impacts on outcomes and its influence on staffing considerations are central to the success of a health equity plan. The ACO Reach, it's in the application, the importance of technology is called out specifically. And so we feel that our platform will provide a great advantage, a differentiator as you implement your health equity plan. Once identified, there are proven methods of engagement, monitoring, and interventions using technology. With the focus on health equity, those of us in primary care and family practice specifically are trained to consider non-clinical influences of health. For those of you who come from a different background, welcome to the party. With ACO Reach, CMS and CMMI have placed a stake in the high ground requiring a detailed health equity plan. Applying relevant benchmark Joe, I think I've gotten out of sync here. If you'll advance the slide. Yeah. So again, with ACO REACH, CMS and CMMI have placed a stake in the high ground, requiring a detailed health equity plan. That requires applying relevant benchmark adjustments, expanded demographic data collection, and an enhanced beneficiary engagement incentives and other beneficiary enhancements. Next slide, Joe. In addition, and in alignment with CMS's stated strategic pillar to reduce provider burden, CMS has moved away in this program, moved away from the traditional focus on clinical quality measures to an exclusive focus on utilization and patient experience. Some of the challenges with administrative claims measures became evident as we evaluated this shift. The specifications are somewhat of a black box, and Lifebeam has invested heavily to create an accurate, reliable replication of these administrative quality measures. To follow the that will allow you to follow your progress over the entire performance year. At this point, we're going to offer an audience poll. It will ask about your planned participation in ACO REACH. If you can just take a minute to select the answer most appropriate for you.
Hey guys, this is Garrett. Okay, so yeah, we've got some answers coming in. We'll give everyone about 10 more seconds. Okay, we've still got a few answers coming in, just a couple more seconds here, and then we will show the results. All right, let's go ahead and wrap it up here. Okay, so let's show the results. Okay, I don't know, Dr. Locklear, if you were able to see the results, but I can read them out here.
Sure.
If not, so the poll results here, the audience should be able to see this, but we had 5 different selections. The first is no, and the question again is, are you participating in ACO REACH? The first question, no. Rejected, did not apply. That's 12% of the audience. Yes, and were approved. That's 23% of the audience. Yes, pursuing. That's 12%. Yes, affiliating. That's 4%, and no, not applicable, not an ACO, and that's about half of our audience.
Very good. Well, as I said, whether or not you are planning to participate in it, looks like we have a mixed group. We do feel like our continued discussion and the focus on health equity will have value for all. What we've elected to do with our presentation today, in working with providers and payer organizations over the last 10 years, we have accumulated valuable experience relative to what are likely strategies and tactics for success in value-based care. But perhaps more importantly, we have also learned where there are some classic pitfalls, and some of these we know are specific to rolling out an effective health equity strategy. So the first pitfall that we're going to address is having too broad a risk stratification and identification strategy. Traditional risk stratification does not place sufficient weight on non-clinical social vulnerability factors when considered. Often they're too general and they fail to provide guidance towards individual assessments and interventions. So that's pitfall number one, too broad a risk identification. Pitfall number two, that your SDOH strategy is disconnected. What do we mean by disconnected? Well, it can be disconnected in two ways. You can be disconnected technically from the right complete data set. So your data set may be episodic. It may require too much manual data entry and manual manipulation. It may be reactive rather than prospective and proactive. So there are technical disconnects. There's also the concept of being disconnected from the broader community and from the community partners who need to be equipped to intervene on the behalf of the patient. So technological tools, technology that allows us to bridge that gap and to broaden our reach and our collaboration within the broader community are necessary for a complete strategy. Next pitfall. Again, if we fail to reach the most vulnerable, our strategy's been effective. For years, we have relied on face-to-face encounters to drive most of our interventions. And even if we consider some of the more contemporary methods, such as telehealth or portals, they can become inadequate when dealing with the most vulnerable in our populations. They also, the strategies typically deployed that are labor intensive can create some problems when you're resource constrained, which brings us to the fourth pitfall. And that fourth pitfall is that we miss opportunities due to staffing limitations. So who is not out there is not currently dealing with staffing challenges? We have not run into any clients, prospects, our colleagues in the industry that are not facing staffing challenges at the current time. It goes without saying that the deployment of effective technologies, organizations will continue to struggle to address the needs. And with the emergence of two-sided risk, the stakes are increasing every day. The fifth pitfall. The fifth and last pitfall is the balancing of quality, utilization, and satisfaction. So certainly if you consider over the last 5 years, for sure, it's been harder and harder to distinguish oneself based on quality alone. The average quality score is now up to 94%. It's been over 90% for some time. And so for a long time, we've known it's going to become more and more difficult, again, to distinguish yourself. CMS has essentially acknowledged this fact by moving away from the clinical quality measures in this program. No one, however, is suggesting that quality is not critical. There's not a suggestion that you should move away from all the great things that you've accomplished in achieving these remarkable performance scores. That has to continue. But the reality is exceptional performance on quality did not sufficiently influence the total cost of care. And so now the shift to utilization with the 4 administrative claims measures that we discussed earlier, and of course the 9 CAPS measures that are part of this program. With that, I'm going to turn it over to Joe to pick up the presentation.
Thank you very much, Dr. Locklear. And to really build right off of that first pitfall, the broad, having your strategy being really built on too broad of a risk identification strategy. And the crux of that is when you look at traditional analytics, it really stops at simply assessing or even really just identifying a particular risk factor for a particular patient. And it fails to go the several layers deeper that are really necessary to make a meaningful impact and utilize that identification, which is asking the question of the data, why is this patient at risk? And then what could be done to do something about that risk? What action could be taken? And that's something that we at Lifebeam, and especially with our Javion product, is really intended to dig beyond just that surface level and dig deeper. And the first way that we'll share how that's done is assessing community level health equity. And it's building all of the data set around all of the data that you see here on the slide. And this is not just a simple classification or even a logistic regression that's happening, but there's advanced clustering where we're looking at the interactions of how this data interfaces with each other to truly make meaningful insights into why a community has particular health equity vulnerabilities. And to give you examples of some of the data that goes into these community level models, I have shared a list of the high level categorizations, but really there's over 900 different characteristics that go into building a robust community level assessment of particular health equity vulnerabilities. And this, no doubt, is incredibly helpful from a planning perspective, and especially as the ACOs that are launching into REACH are trying to understand high-level areas that they will need to focus on. This is a great first step, but of course there's appetite to take it then one step further yet again and say go beyond community level data and dig into individual patient level data. So adding to the data set, to the profile of not just the community level data, but adding in patient behavior data and social determinants of health data. This is where we can get a very, very robust picture of what actions could be taken on an individual patient level to close the gaps and identify those opportunities that are going to make the most meaningful impact on that patient's health and overall well-being. And of course, you may very well be familiar with the CDC's SVI tool that looks at different dimensions of health equity as it relates to the ACO REACH program. Now, it's important to keep in mind that the CDC's SVI was really originally designed to be able to understand how prepared a community is to rebound from a natural disaster. And when looking at the SVI as a model to predict utilization on a patient level, you see that for broadly speaking, when you're looking at these kinds of models, you look at an R squared of greater than 0.5 to be able to say that there's truly a positive correlation. And the SVI falls short of that. The R squared is 0.48. But that when you look at Javion's individual model of being able to identify and elevate the opportunities that could make a meaningful impact and using that to see how that's predictive of the overall utilization, you see that R squared is much more powerful. R squared is 0.89. So again, going beyond just a simple classification, but looking at the advanced clustering, you could see really the opportunity to bend the overall cost curve and again, meet the patients where they are with individual targeted needs. But of course, the spirit of the program, as Dr. Locklear mentioned earlier, is not to think about a health equity strategy just in its own silo or own vacuum, but to also think about how the overall health equity for that community, or again, down to that individual patient level, also interfaces with their overall utilization patterns, as all of the ACO REACH groups have at least 50% or 100% risk downside exposure. So leveraging also JVM models that can predict all-cause readmissions. And you could see how it's far more accurate than something like just a LACE score. And you could see how it reduces a significant amount of unnecessary clinician outreach by identifying those needles in the haystack of not just those patients that are most at risk for readmission, but which patients, when acted upon, also have the ability, that your team has the ability to influence that outcome as well, which is many times a crucially missed insight that's taken into account. And we'll actually be able to share some specific evidence and numbers around that a little later in the conversation. So to pull this together from assessing the risk, right? Step one, going back to the original pitfall, taking too broad of an approach to assessing the risk within your population, you should really be thinking about how do you put together an integrated strategy that is able to leverage community level data, individual level data on a health equity front, but also clinical utilization data to be able to build the right profile of the patients and specifically the opportunities for action that can then help those patients and also help your organization succeed. And with that, I'm then going to allow Dr. Locklear to speak to our second step in the roadmap.
So our second step, thank you, Joe, is monitoring. And there are many important aspects of leveraging technology to monitor the vulnerable and the high risk in your population. You'll go to the next slide there, Joe. Leveraging automation to identify subpopulations based on specific attributes and risks is critically important. Also, using technology and automation to initiate escalations, bringing critical information, critical events to the forefront so that you don't find out about them too late or after significant deterioration in health, further complications or avoidable costs. And then the third is not only to initiate those escalations, but also to use technology to trigger interventions. The summary of this is a powerful cohorting capability coupled with relevant automation does two important things. It expands your capacity and your reach in your population. It also optimizes your outcomes. Next slide there, Joe. Another place where we found tremendous value in technology is with the important transitions of care. And we all know that transitions of care are a critical juncture in the healthcare delivery process. The CMS implementation of the 21st Century Cures Act has highlighted the critical nature of technology and data sharing by making the delivery of ADT information a condition of participation in Medicare for hospitals. This was something that was talked about for many years and finally, again, implemented with the CMS deployment of the 21st Century Cures Act. At Lifebeam, we have always appreciated the importance of elevating the visibility of this information. Near real time, and when I say that near real time, I'm talking about within 15 minutes or less, Lifebeam can deliver this information to providers and/or the provider's frontline staff. This allows you to leverage that technology both to the benefit of the patient, connecting their healthcare processes and their healthcare path over time, but also reducing avoidable events such as readmissions, additional ED visits, and the like. Next slide, Joe.
Very good. So step one, you saw how Lifebeam's Javion product is able to leverage the data sets that are most impactful of identifying, assessing, and then prescribing specific interventions that can have a meaningful impact on the patients. Step two, you saw how Lifebeam's cohort builder and ADT insights allow you to set the monitoring and the automation to really identify the cohort level strategies that you want to implement. Step three is focused on Lifebeam's CareSignal product. And that really builds off of the pitfall of the disconnected social determinants and overall health equity strategy. Dr. Locklear really shared it well up front that there's several ways that your strategy could be disconnected. And I think one that particularly hits home is thinking about how historically social determinants has many times been thought of as a once a year form that almost like checking a box. You're trying to collect that assessment on behalf of your patients once a year to get some kind of understanding of what particular areas your patients may need the most support. And that's challenging when many of these factors are dynamic and change on not a year-over-year basis, but on a much more frequent basis. And one to think about is something like housing. If someone is identified as particularly vulnerable around having stable housing and making rent or making utility payments, those payments are many times due once a month. So why are we only asking about the vulnerability once a year, when we could be asking those patients on a monthly basis, how are they doing that month? So that's really what we're doing here as far as enabling a successful strategy, that it's not enough to just assess and monitor, but actually take action and make those meaningful connections. And at the bottom there, you see there's many of you have already taken the steps of partnering with a NowPow, a Unite Us, a Find Help, and the Lifebeam platform has been built to where when those actions and those opportunities for intervention are elevated, to very quickly connect out to those platforms that you're using to be able to find what resources in that particular community are available to be able to help that particular patient pay their electrical bill this month. And again, close that gap with incredible precision and speed. Now, the way that we want to ask these questions to build on the second disconnected strategy that Dr. Locklear mentioned is really the technological component. The way that you engage with patients around health equity needs to meet them where they are, from a technology literacy standpoint and a health literacy standpoint. And so it is not appropriate nor sufficient to be asking these questions that require an app, that require passwords, that require downloads, all those traditional things that we know overall just struggle with patient adoption. The patients that many of you will be engaging with the program need to be able to be reached in ways that they're comfortable with and are accessible to them on on an ongoing basis. So it's not even enough to just simply ask these questions via text messages or phone calls. The Lifebeam's CareSignal product has taken the step of even signing agreements with all the major cellular carriers to do what's called free to end user texting. This means that patients on pay-as-you-go phones can send and receive text messages engaging and providing updates about their health and their overall health equity on a month-over-month basis without ever counting against a pay-as-you-go plan. Again, reducing the barriers, finding ways to make meaningful connections with patients. And many times, text messages may not be appropriate, especially looking at an overall breakdown of text versus phone call based on age group. CareSignal's, when outreaching to patients, offering to enroll them in these programs, offers both text messages and phone calls. And you could see between 60 to 79, it's a fairly even split. But that once you go above patients that are above 80 years old, you see the vast majority actually prefer the automated phone call version, where it's simply touch tone responses. Again, it's familiar technology. Everything's written at a 4th to 6th grade reading level. And we're not also just asking questions about social determinants. Again, going back to really the entire thesis and premise of the REACH program is to not think about health equity in the silo, but to think about it in a very connected way. And it's to connect, not just asking about food security, but also asking about blood pressure, blood sugar, or perhaps not just asking about transportation or utilities, but also assessing overall mood, or potentially even administering a PHQ-9 on a monthly basis. And you can see how the programs within Lifebeam's CareSignal portfolio are designed in a very evidence-based way and have been now published in 13 peer-reviewed publications. And you can see several of those outcomes highlighted on the right-hand side. But then going back to the pitfalls, pitfall number 4 was talking about staffing and how the entire industry is suffering from just a chronic lack of capacity of clinicians to be able to do, especially this kind of proactive care outreach. That's why Lifebeam really established the Lifebeam Clinical Services to be able to serve as a natural extension of your team, to be able to do initial triage, do initial follow-up, and you could see even do targeted programs, whether it's annual wellness visits, chronic care management, transitional care management, to be able to help meet the overall market needs, especially as it relates to staffing. And so I'd like to bring this section really together with kind of thinking about how do all of Lifebeam's products come together to develop into one overall patient experience that is going to be really transformational when it comes to thinking about building and executing a health equity strategy within REACH. So the first step you saw, again, was taking the data from both the data sets available to you today, but as well the community and even the patient behavior data to surface those top opportunities for patients for intervention to make a meaningful impact on patients. You then add in that constant monitoring of Lifebeam's cohort builder and especially the ADT insights as it relates to transitional care. From there, it's actually not on your team. It's on Lifebeam. We will reach out to each one of those patients that would benefit from those extra texts, those extra phone calls, that extra level of engagement, educate those patients about the program, gather their preferences of what day of week, what time of day is going to be best for them, most convenient for them, and enroll them in those programs. From there, there's that ongoing engagement and enablement of assessing this patient is having a particular concern, whether it be clinical, like a hypoglycemic event, or around health equity, like a particular concern around paying rent or utilities. elevating then those alerts, yes, could go to your team, or again, the Lifebeam clinical services team could be acting upon those as an initial layer of triage, serving as a natural extension of your team, and then simply only escalating to the providers when there's a situation that warrants it. So with that, I'll then pass it back to Dr. Locklear to bring it home with step 4 on our roadmap.
Thank you, Joe. Again, our last step is measure, and we all know that we can do tons of good work and feel that we're making a difference, but if we can't measure and demonstrate that progress, we'll run into challenges. Data proliferation is a real issue. You really can't attend a session where we're talking about technology without someone mentioning the proliferation of data. From a practical sense, though, what does this mean? It means that it's a challenge to putting the meaningful information in front of the people who need it and have to have it to do their jobs well. These can be executives, they can be practice managers, they can be providers. Everyone really in the healthcare value chain needs to have insights into how they're performing in order to continue to move the needle in a positive direction. Lifebeam has invested heavily in developing formats that are easily consumable and that facilitate appropriate activity and action, and that they are use case specific. So in this case, we're talking about ACO REACH, and we've developed dashboards specific to that need. So Joe, next slide. So in summary, achieving success in ACO REACH, that's what we're all after. You can substitute, again, if you're not participating in REACH, substitute a health equity plan, achieving success in a health equity plan. In any case, the 4 elements: assess and identify the patients that are most vulnerable and have the highest accumulated risk, and hopefully that risk, the risk you focus on, will be modifiable risk. Number 2, deploy dynamic monitoring using real-time data. Number 3, leverage automation and augment staffing with technology that patients appreciate and adopt. And lastly, track your performance in real time with use case specific, in this case, ACO REACH specific metrics and displays. Next slide, Joe. So evidence, we can say all we want, but what evidence do we have to support our proposition? Who doesn't love a good patient success story? We have a lot of them. I'm going to share one of them here with you today. 64-year-old female. She has some of the classic chronic conditions we all see in our practices. And she's also has, as all patients do, a unique set of social vulnerabilities, and that she has needs and considerations that play into her course through the healthcare continuum. That illustration of that that patient journey that Joe illustrated. So the patient has engaged with the healthcare system. The Lifebeam platform has acquired the classic information, also surveying and risk assessing based on social vulnerabilities. has identified this patient as being at risk for avoidable utilization in the future, and has made a set of recommendations specific to this patient's clinical and social vulnerabilities. Next slide, Joe. Okay. Effectiveness and efficiency. What we're talking about here, we would call precision. So would you prefer to have to engage 600 patients in an evaluation process to find out and prevent 5 potential admissions? Or would you like to reduce that number to 32 patients using the Lifebeam platform and all the technologies we've referred to prevent that same number of admissions? So that's what we're talking about the appropriate identification, the assessment, the monitoring, the intervention, and the interventions. This is what our results demonstrate. Next slide, Joe.
Hey guys, seems like we might be having a little audio issue here. Dr. Locklear, are you able to hear me?
Yeah, I can hear you, Garrett.
Okay, I'm sorry. Looks like okay. We're back on.
I think we may have lost Joe temporarily.
Sorry about that. I'm back. Just it wouldn't be 2022 without audio connection issues.
Oh, yeah.
So thank you, Dr. Locklear, for going through the patient success story, as well as focusing on the care management efficiency. Taking that again one step forward of thinking of specific quality metrics again that are going to be crucial to overall success in the REACH program. Of course, will be readmissions and transitions of care, and we have a case study with again Lifebeam's Javion product of reducing readmissions by over 23% on top of what was truly a pretty sophisticated transitional care management program standard of care at Northwell Health. So you could see in this case study how Northwell saved over $450,000 in just 4 months by, again, identifying those specific opportunities where intervention are most likely to have a meaningful impact on readmissions in this case. And taking that then from a specific quality metric perspective to truly an enterprise level perspective. This is a case study with a large health system in the Midwest where they deployed Lifebeam's CareSignal product. And this particular group enrolled over 35,000 patients in one of the largest remote patient monitoring implementations in the US, and was able to calculate a $32 million in cost savings in just under 5 years. And you could see that while also seeing some pretty significant impact on overall care management efficiency and scalability, which again will be such a crux to success, and not just immediate ACO REACH, but as ACO REACH groups are looking to scale and take on more and more and more overall at-risk lives. So with that, I am actually going to toss it over to Garrett, I believe, to lead us through some of the Q&As.
All right. Yeah, we did have a number of questions come in, and just as a reminder, if you would like to ask a question, go ahead and do so now using your control module. There is a little area for questions, and so you can just ask them right there. We're going to get to as many as we can. So without further ado, let's jump in here. First question, and this isn't directed at either of you necessarily, is can you speak to how you support identifying and closing gaps in care?
Yeah. Dr. Locklear, would you maybe want to take that one?
Sure. So, so a core capability of Lifebeam is the ability, regardless of the type of gap in care. So there are obviously clinical gaps in care. There are, there's a focus on some HCC related gaps in care, but there are also social vulnerability, SDOH gaps in care. With our platform, you have the full complement of incoming data, the ability again to sift through with some levels of priority who requires the attention at the current time, identify those patients either through cohorting or through an analytics process, elevate those patients to the exposure of the people who need to intervene, and provide your staff tools with the ability to generate those interventions. In some cases, those interventions can be, those outreaches rather, can be augmented through automation, as we discussed. If all that's required is a reminder that something needs to be scheduled or that the patient is overdue, that lends itself very nicely to automation. If it requires a more detailed intervention, those patients can be, the exposure for those patients can be elevated to an individual. That individual can be part of your staff or part of a Lifebeam Care Services.
All right, great. So next question is, do you integrate into Epic, and what does that process look like?
Yes, so Lifebeam was the first population health platform to be certified by Epic on their app Orchard. Epic in recent years deployed a new methodology called Kit and Caboodle in order to facilitate access to important data. Lifebeam has been through that entire process, and we have clients who are active on this this integration out in our current client base. So the answer to that is an absolute yes.
Okay, great. Moving right along. Next question is, how do you prevent leakage and out-of-network utilization?
Well, there are several ways from a Lifebeam perspective to put in place a plan to avoid that. So let's talk specifically about ACO REACH. So in REACH, we all know there are three types of provider categories. There are your participating providers. Those are the providers that are closely aligned with the organization. It is through participating providers that the patients are assigned or attributed to the REACH organization, okay, so tightly aligned. There's a next layer out, which are called your preferred providers. Now they are under a contract with the ACO REACH organization, so they will be again aligned with the organization, but patients cannot attribute, patients cannot assign to a preferred provider. And then there's essentially everyone else in the Medicare universe. One of the things that we know will be important will be to provide information about where care is being received. The expectation, because of the qualifications and the benefits that Medicare patients receive when they participate in REACH, there can be no reduction or no modification of traditional Medicare benefits. That Medicare patient can go to whatever provider they so choose, okay? That may be their participating provider. It might be a preferred provider. It could be a provider completely outside the network. It's going to be important for the REACH organization to understand where that care is being delivered, okay? Is it being delivered and delivered well by their participating providers? Is it being delivered by preferred providers? And what is the quality and the efficiency of that care? And then what's going on in that outer band, everyone else that's a Medicare provider? Incredibly important. And so this tool will allow people to understand where care is being delivered. It's not, you know, again, according to the REACH specifications, it's not quote unquote a network, but it is different levels of affiliation, and you're going to want to understand where and how that care is being delivered, both from a quality and an efficiency standpoint. We also have tools in Lifebeam at a more general level. We have a component called Referral Point, which is a referral management module, which allows an organization of any type to create information, disseminable information within the organization about referral options, what the relationship is with the organization, an in-house referral versus an out of practice referral, and some characteristics about each of those referral providers, their location, languages supported at that office, some information, some general information about cost and about quality. So we have many tools in Lifebeam to help organizations manage the referral process, appreciate leakage, make adjustments to their organization, the structure and component members of their organization. That was long-winded.
All right, no worries, no worries. We're moving on here. Next question is, how long do patients engage in your RPM program?
Yeah, that's a really good question, because for especially a program like REACH, many times yes, readmission is certainly a focus where that has a certain time horizon where you are being measured by, but overall you're trying to keep as many patients as you possibly can engaged for as long as possible. And so because of the design of the accessibility of text messages and phone calls of Lifebeam's CareSignal product, 1 out of every 2 patients are still engaged on a weekly basis a full year after initial enrollment. So again, this is certainly impactful in a post-discharge setting, but think about this in a much more longitudinal management approach.
Okay, great. Next question here. Let's see. How can you measure the effectiveness of a health equity plan? And kind of a second part to that question is, how can you sell the value internally?
Yeah, great question. I'll take the first part of that, and Dr. Locklear can take the second. When you're thinking about measuring the effectiveness of a health equity plan, I would think about it in twofold. One being a more short-term measurement of just the amount of connections that you are making with patients in your community. So again, don't think of this as just, oh, I've identified a certain amount of patients, but think about the action, think about the interventions that you're having as step 1, but then ultimately you're responsible for the overall utilization. So and again, not just thinking about this through the lens of how successful were you in just making connections to community resources, but how is that ultimately making an impact on utilization and shared savings within the REACH program. So I'll let Dr. Locklear speak to how to make that case internally.
Yeah, so the case for health equity, I would argue in 2 ways. So let's talk about the practical one first. So what we're talking about here, when we're talking about a health equity plan, is we're acknowledging that there are people out there who have health inequities currently. If they didn't have health inequities, there wouldn't be any need for a health equity plan. By having health inequities, then they are by definition not getting the care that they need at this time for the conditions and the vulnerabilities that they are currently experiencing. So that's affecting essentially the quality of their care. And we know if the quality of care is not there, the cost of the care is in general going to be higher than it should be, okay? It can be a little bit higher or it can be a lot higher, but it is going to be higher. So that is the practical justification for a health equity plan. Here's the other justification. It's the right thing to do. The fact that we have significant health equities in this country and they have persisted as long as they have should be a black mark on our entire system, okay? So it is the right thing to do practically, it's the right thing to do financially, it's the right thing to do morally, and we should all get behind it as quickly as we can, and it's overdue.
Wonderful. We have a time for just a couple more quick questions here. The next question is for ADT notifications for ED visits. Do you have a nationwide solution or is that a region-specific thing?
Garrett, read me that question again.
Sure.
I had a little.
Sure. The question says, for ADT notifications for ED visits,
Yeah.
do you have a nationwide solution or is that a region-specific?
No, this solution can be deployed at any location. The requirement, the only requirement is that we get the ADT transactions from the relevant inpatient facilities. If we have access to those ADT transactions and they are coming in to that system, to that client system, then we can plug them in to the ADT Insights process. We can deliver, so that in a little more detail, the ADT Insights includes an active dashboard that anyone who's credentialed within the hierarchy can see at the appropriate level. But beyond that, it does deliver those near real-time escalations to the appropriate designated individual within the practice or even the provider themselves.
Great. Well, we are running out of time here, but I have time for one last really quick question here is I'm not participating in ACO REACH. Can this be used for non-ACO REACH populations?
Yeah, absolutely. We are building our health equity capabilities for the larger use case, the broader use case. We talked specifically about ACO REACH today, but CMS has already released other programs that have a health equity requirement. Our solution will support any of those programs. It will support if an organization decides they themselves on their own want to deploy a health equity strategy. We can work with them effectively. Our tools are not specific to ACO REACH. Our health equity tools are available for any use case.
All right. Well, guys, that is unfortunately all the time we have. If you have another question that is burning, please ask your question. We'll get back to you via email afterwards. But right now, we've got to wrap it up. As we close out, and first of all, thank you guys so much. Thank you, Dr. Locklear. Thank you, Joe. This is a wonderful presentation. I know I got a lot out of it. I hope everyone else here did too. As we're wrapping up here, I wanted to encourage you all to visit the CareSignal and Lifebeam booth at vbcexhibithall.com. And here's where you can dive down a little bit more on some of their initiatives within value-based care and what they're doing, and engage with the team there. There's a lot of cool resources. And also, this is on vbcexhibithall.com is where the recording will be housed in our library. You can actually search for it under webinars. But I am going to be sending out the recording to all the registrants here after in a couple hours. You should receive an email with a link to the recording and where you can also download the slides. And then lastly, if you have any questions for either of our speakers, or for the CareSignal or Lifebeam team, feel free to reach out to them. If you could go on to that last slide for me, Joe. And okay, so if you guys wanted to reach out, I thought it had the contact information here. That's okay. Reach out to me, or feel free to reach out to them, and we'll put you in touch, and we'll be happy to facilitate an introduction. So lastly, thank you all so much for attending. I know that you got a lot buying for your time these days, and we really appreciate you spending the afternoon with us. Hope you have a wonderful rest of your week. Thanks for coming.